on average, about 20 to 25% of children with ADHD will develop this pattern of fearfulness, worry, panic, anxiety, and other associated symptoms of an anxiety disorder. Now, the risk for anxiety disorder increases with age as long as the ADHD is going unmanaged. So, for instance, while 20% of children with ADHD might develop an anxiety disorder, if it isn't treated early and the child goes on to experience a number of failures in their life, then the rate of anxiety begins to increase, so that by the time we see adults with ADHD, for instance by age 30, the rate of anxiety can be as high as 45% or more, nearly doubling between childhood and adulthood when the ADHD is unmanaged. The reason for the development of anxiety disorder is once again the poor emotional self-regulation that we see in ADHD, often combined with increased failure experiences due to ADHD, which lead the individual to become more anxious or fearful about situations in which they may have experienced previous failure. So it's rather obvious why anxiety could develop in some children. It may also develop because of a higher risk of anxiety in the parents. We do know that there is some genetic contribution to anxiety disorders and that it can be inherited from parent to child. And that too could increase this risk of anxiety developing in the child, besides the failure experiences that I've already mentioned. The risk of developing an anxiety disorder in children with ADHD is related to their impulsive behavior and emotion regulation, as well as to the earlier development of their inattention. These children often have been exposed to much more disruptive, stressful, or otherwise adverse social circumstances in their lives, possibly even child victimization or abuse. These children may also be more likely to have another disorder known as autism spectrum disorder, which, as we know, is often associated with anxiety and panic attacks. And again, I've mentioned parental anxiety disorders also increase the risk of a child developing an anxiety disorder. Interesting, where an ADHD child also has anxiety, it seems to make them less impulsive, less willing to take risks, less likely to develop reactive aggression. And all of those are good things because they lower the future risk to the child of other impairments that might be associated with impulsive and risk-taking behavior. So we may see one disorder, anxiety, lessening the likelihood of a child having other problems in their life that go with ADHD when anxiety isn't present. It's almost as if one disorder is somewhat protective when it occurs with the other disorder, in this case, anxiety with ADHD. Now, these coexisting or comorbid cases of anxiety with ADHD may have additional risks, however, that are not seen in ADHD children alone. And one I've already mentioned is a future risk for developing depression by adolescence or adulthood. We may also see a greater risk of depression in both parents, mother or father. And there might be a greater history of bipolar disorder among the parents or the extended family members. So, having an anxiety disorder isn't always protective of all other risks a child may have, even if it reduces impulsiveness and risk-taking, it may bring with it an increased risk for depression. And then, of course, anxiety disorders are associated with social withdrawal or social impairment when they occur. So that brings another problem into play. Recent studies have shown that these anxious ADHD children are the most likely to develop sleeping difficulties, problems falling asleep, not sleeping very well or efficiently, frequent night waking, and even earlier rising than normal, thus resulting in a child who is unusually tired the next day, for instance, in school, and may be more inattentive as a result. So we do want to manage these sleep problems where they coexist. I'll have more to say about that later. So if anxiety occurs with ADHD, does it have any effect on managing the ADHD? Well, the first thing it should tell a parent or a mental health professional is to try to check out or probe whether or not the child has been victimized, such as by bullies at school, or have been exposed to physical or sexual abuse by another adult. This is especially true where the child has gone on to develop anxiety very quickly, along with other complaints about their body, such as psychosomatic symptoms, stomach aches, and headaches, for instance. So, a rapidly developing pattern of anxiety may signal a child who has been exposed to abuse or other victimization. And of course, we need to know that so that we can take steps to eliminate that from happening again. Interesting, anxious children are more responsive to psychological treatments for ADHD than are typical ADHD children who don't have anxiety. It's not clear exactly why that would be the case, but it has been found in several studies. Now, cognitive behavioral therapy is a treatment used for anxiety, and it may work well in children who have ADHD with anxiety for managing the anxiety, but it's not going to do anything for managing the ADHD. But that doesn't mean that we won't try it. We're most likely to recommend this form of cognitive behavioral treatment when anxiety is present. And of course, if the ADHD has been treated with medication, the child may be even more responsive to cognitive therapies for managing their anxiety because the ADHD is no longer interfering with their treatment response. We also want to counsel parents on how to deal not just with the ADHD through behavior management training, for instance, but also on things they might be able to do to reduce anxiety in the child. Sometimes the child's anxiety is partly related to having an anxious parent who displays their anxiety in front of the child and is therefore modeling anxiety and making the child more fearful or sensitive than they otherwise might be. So we need to focus our behavioral intervention sometimes on helping the parents to cope better with their anxiety, and this may then help with the child's anxiety as well. Parents who have anxiety are less likely to be rewarding or reinforcing of their children. They don't punish them more often than others, but they are less likely to reward them for good behavior. So one thing we like to focus on in working with parents, especially anxious parents, is to increase their use of approval, praise, recognition, privileges, and other rewards given immediately after good behavior is shown in order to increase this frequency of reward, of positive consequences, and thereby improve the child's behavior accordingly. Earlier studies suggested that where anxiety was present in ADHD, one should not use stimulant medication like methylphenidate for fear that it might make the anxiety worse. But subsequent studies over the last decade or two have suggested that that was not true. That not all children who had anxiety and ADHD were not responsive to a stimulant or were made worse by it. So we now recognize that many children who have anxiety with ADHD might be able to take an ADHD medication without it worsening their anxiety. But should this be a concern, or should the trial on a stimulant result in increased nervousness or anxiety, then the non-stimulant Strattera is a more effective alternative, because Strattera has been shown to improve anxiety in addition to the improvements it produces in ADHD. And that is why many countries that have developed guidelines for the management of ADHD often recommend that Strattera be considered a first-choice medication where these two disorders coexist. Yet another disorder that can occur in ADHD children and teens that I've already mentioned, but I'll talk more about it now, is major depression, abbreviated MDD for major depressive disorder. It's a little less common than anxiety, occurring in perhaps 15 to 25% of ADHD cases or less. It often is not seen in childhood in full form of major depression. Typically what we see is low self-esteem. But by adolescence, the depression may have become more obvious, particularly, again, if the child with ADHD has experienced a lot of failure or has been exposed to other adverse social situations. So it takes both ADHD as well as a genetic vulnerability toward depression. Remember I said that ADHD shares risk genes with depression. So having ADHD genetically increases the risk for depression. But where these two disorders are likely to co-develop, it's often because the ADHD child has had repeated emotional distress or even trauma exposure or experiences. So the risk for depression might be able to be mitigated or reduced if we treat the ADHD early and prevent these failure experiences from occurring, or at least occurring less often. And therefore, we might reduce the future risk for depression. As I've said, we can begin to target or identify which ADHD children might go on to have depression by adolescence, because unlike typical ADHD children, these children show a pattern of very low self-esteem, dislike of themselves, and in general, a loss of pleasure in normal, pleasurable activities of childhood. The word we use in psychology is anhedonia to describe that reduced sense of pleasure from life. So where that is seen, the child needs to be evaluated more thoroughly, followed more closely, in hopes of preventing the development of major depression. As with anxiety, where depression occurs with ADHD, we also want to make sure the child has not been victimized, either by bullying at school or through some other forms of exposure to abuse, such as physical or sexual abuse. This is especially likely to have occurred where the depression develops relatively rapidly, as I've already explained for anxiety as well. Of course, where a child develops depression, it's easily understandable why this would increase the risk for suicidal thinking by adolescence or adulthood. Depressed people, of course, are more likely to think about suicide attempts than are others. But it is the ADHD and its impulsiveness, when depression is seen, that markedly increases the risk of a suicide attempt. So, depression may cause a child to think about suicide, but impulsivity may lead them to make the attempt more likely than might a child without ADHD who is also depressed. Now, the peak risk for suicide, suicidal thinking or attempts, is in the high school years and early adulthood. So the risk increases with age to adolescence and then begins to decline as we move into adulthood. So that is why one has to be very concerned when one sees a teenager with ADHD if we have already seen them develop major depression, because that will be the child at high risk for suicide who is going to need interventions to prevent that from happening. When depression and ADHD coexist, we will treat the ADHD first if the depression is relatively mild, the ADHD is the chief complaint or concern, the ADHD symptoms are more severe and disabling than are the symptoms of depression, which are mild, and where there are no psychosomatic symptoms that are seen, known as vegetative signs, such as disrupted sleep or disrupted eating patterns. So, where the depression is mild and the ADHD is the worse of the two, we will treat the ADHD first, because sometimes that reduces the depression or the risk for developing depression. On the other hand, where the depression is more severe than the ADHD, particularly where we are seeing those vegetative signs of disrupted sleep and eating, where the individual may already have engaged in suicidal thinking or have even made a suicide attempt, then clearly the depression needs to be treated first, usually with a combination of antidepressant medication and psychological therapies. Once the risk for depression has been reduced, then we will go back and treat the ADHD, most likely by adding an ADHD medication in to the other package of treatments used to manage depression. Because you see, the drugs for ADHD are not very good at treating depression where it has occurred already. And the antidepressants are not very good at managing ADHD. And that's why we choose to manage the worst disorder first with its own medication. Eventually, we will see a pattern of mixed medication use, where both an ADHD medication and an antidepressant, such as an SSRI for serotonergic selective reuptake inhibitor, where an antidepressant might need to be combined with it. And as I've said, that's because that the stimulants and Strattera, or atomoxetine, don't treat depression very well. Depression is very responsive to cognitive behavioral therapy, so that may need to be added into the treatment package, even if it doesn't do very well at treating the ADHD. It can help the depression. Because there is a genetic risk for depression, we like to screen parents to see if they might also have depression, and that might help to explain the transmission of the risk for depression by heredity to the child. Where the parent has depression, we need to treat that also, because the parent is also likely to be irritable, emotional, hostile, explosive, and more prone to using punishment with the child. And that's why when we work with such parents who have depression, we often do not teach them forms of discipline, but instead focus on all positive consequences for helping to manage the child's behavior, going very slow in introducing negative consequences until the parent's depression has been reduced